في المنطقة الجنوبية، ونتوقع منكم المزيد إن شاء الله كالعادة. وترى الجنوب دائما ما شاء الله مبدعين في أعمالهم، ما أنهم كلهم شيء، لهم ما شاء الله التوب أولويز. بالتوفيق، وشكرا دكتور محمد for starting the talk، ودكتور عبد العزيز and the organizing team from the South Club، وبالتحية لكم، وإحنا معاكم أيضا. we are the listener also for you today.
Thank you, Prof.
طيب، بسم الله الرحمن الرحيم. First of all, I would like to thank the SASMBS for organizing this Bariatric club. I would like to thank Dr. Abdulaziz Arishi, the director for the club, the chairman, Dr. Al-Amri, and the coordinator or the moderator of the club, Dr. Abdullah Dalbouh and Dr. Taqir Al-Shehri. It's an honor for me to be the first presenter in the South Region Bariatric Club. The topic that been chosen for the first club is what are the surgical options for recurrent weight gain post-sleeve gastrectomy if a patient has a hiatal hernia. Actually, I'm going to talk about the weight regain in general definition, then I will go for the hiatal hernia and the reflux associated, and what are the optimum procedure, if there is an optimum procedure for such patient. Weight regain post-sleeve gastrectomy has been observed with studies reporting that almost close to 50% of the patient may experience some regain over long term, in 3 to 5 years from the primary procedure. Common risk factor including poor dietary habit, lack of physical activity, emotional eating, and inadequate or post-operative follow-up. Genetic factors play a major role too, with the psychological condition and the presence of comorbidities like diabetes can also contribute to the weight regain. So some research focuses on the metabolic changes after sleeve gastrectomy, such as alteration of the gut hormone like ghrelin, GLP-1, leptin hormone that might contribute to the weight regain. The role of gastric pH and the stomach capacity to expand post-surgery also has been studied, and as this could affect satiety signals and contribute to the overeating. Bariatric surgery is generally superior to non-surgical weight loss intervention, and a significant proportion of patients achieve less than expected benefit due to suboptimal weight loss or weight regain. So in general, how we define the suboptimal weight loss? It's defined as not achieving a weight loss 40 to 60% of the baseline excess of body weight, and it happened over 1 to 2 years from the primary procedure, and it occurred in almost close to 20% of the patient. And it defined also as less than 20% of total body weight loss is as it's usually linked to the recurrent of associated conditions like morbidities. Weight regain defined as initially achieving expected weight loss, the expected weight, but we have a weight regain after. So a progressive weight regain or gain after reaching a successful nadir weight loss of more than 20% of total body weight loss. And it defined also there is a concomitant recurrent of their morbidities or comorbidities. So lots of, the data and the literature is full of the data and that support the weight regain post-sleeve gastrectomy, and there is a big systemic review that revealed that almost there is a close to 76% of sleeve gastrectomy patient has significant weight loss at 6 years follow-up in that randomized systemic review. So why the patient regain weight or to start to regain weight? Procedure failure as a dilated or retained gastric fundus, and we've seen it. Not that frequent, but we've seen it from time to time. And the most common cause are thought to be the dysregulated behavioral eating habit, like loss of control eating. So they don't have that physiological mechanism that play a major role to control the function of ghrelin and leptin hormone. And the maladaptive, like crazy eating, which is more related to psychological problem. Patient keep eating large meal in less than 2 hours and more of a frequent time. The non-compliance to dietary recommendation and returning to previous eating habit that used to be that they have to use to before surgery, and their sedentary lifestyle all are risk factors of weight regain. Physiological compensatory mechanisms such as changes in the hormones that regulate energy intake, leading to increased appetite and food craving like ghrelin, and decreasing the leptin hormone, as well as increased caloric intake. The comorbid psychiatric disorder usually, especially depression most of the time, have also been implicated as a potential cause of treatment failure. So the maladaptive eating disorder commonly reported among bariatric surgery patients, craving, as I said, they eat large meal in less than 2 hours and they do it more frequently, and loss of control eating, and this is more of a physiological imbalance between leptin and ghrelin factor, and the binge eating, those who eat food not because of the hunger factor, or not because they're getting hungry, they're getting by their mood. So depending on their mood and their habit to keep eating. So this is in summary of the few slides that I talk about, like depression, dietary factors, the hormone, less activity or barrier from doing exercise, and sometimes using the exogenic medications, mostly the antipsychotic and antidepressant medication, surgical complication, and inadequate choices of index separation. And in the first separation, wrong choice of first separation, like a big BMI patient, you shouldn't do for them lab band case as an example, and so you have to choose the right procedures for the right patient. You won't be doing sleep hysterectomy for a patient who has a big hiatal hernia and a symptomatic reflux. And the other risk factors like genetic factors, and I'll talk about in the coming few slides. So weight regain is associated with the return of previously controlled type 2 diabetes, hypertension, and other comorbidities with lower quality of life and emotional health. For reversal of the weight regain, revisional surgery can be effective in some cases, but is generally associated with a higher rate of complication than primary bariatric surgery. The published study of pharmacotherapy that we've been using nowadays for weight regain have been mostly retrospective reviews of medical record or small open label trial, and it's appeared that anti-obesity drug induce less weight loss in a patient who had a history of bariatric surgery than when you compare them to a patient who did not have a previous surgery. So, as I said, the resources and it's full of data, and there's almost from time to time we find a conflict in data. Like, believe it or not, prevention of weight regain could be ideal. We can't do it. But unfortunately, there is a big paper that comparing dietary, behavioral, and exercise intervention have demonstrated almost marginal efficacy in replacing weight regain or none. But the sequelae of weight regain, improvement of weight-related comorbidity following the metabolic bariatric surgery, such as diabetes type 2, are related to the amount of weight loss achieved. An all randomized controlled trial that compared metabolic bariatric surgery with medical treatment, those with more significant weight loss had a better glycemic outcome. So the more of weight you lose, the better comorbidity improvement. So weight regain will cause the return of obesity-associated morbidity. So here, how to address the weight regain after bariatric surgery and in individualized standardized way. So here are the strategies. So the strategies in treating a weight regain patient, first of all, it's important to identify the cause of weight regain or inadequate weight loss. This can be done through a comprehensive medical evaluation that includes a review of patient diet, exercise habit, and other relevant factors contributing to the weight regain. It may also involve diagnostic tests like genetic testing for the patient to evaluate the patient metabolic status and gastrointestinal anatomy. Doing a CT scan or CT scan volumetry or barium swallow studies. So all depend on the case that you have. So strategy 1, identification of first of all, we have to identify of non-responder patients. So obesity, it's like any chronic illness like diabetes, hypertension, hypercholesterolemia, has a different individual biological response. So the high degree of variability in weight loss following bariatric surgery may be due to a genetic predisposition to resist weight loss that has not been investigated. So different gene allele carriers predisposed to individual response to surgery. So genetic marker that I'm talking about linked to obesity in common, we classify them into 3 types: the monogenic, the MC4, And it happened early onset severe obesity, often secondary to hyperphagia. They eat a lot. And the second genetic factor, syndromic obesity, that we see it in the children or in the child, Prader-Willi syndrome, hyperplasia, and they have some intellectual disability. And the third common one cause for obesity nowadays, we see the polygenic factor secondary to fat mass and obesity associated gene. We call it FTO, increased appetite and energy intake. And they have some variant of MC4. So those who they have positive gene or they have inadequate weight loss or they have a fast weight regain. Clinician can identify poor responder eligible for different therapeutic options like either adjunct medical treatment or surgical treatment or even endoscopic treatment. As with a new GLP-1 treatment, where early weight loss response with the treatment predict better outcome. And it's the same valid for the metabolic bariatric surgery. So if they respond well from the first time, so it means they are a good responder. So as you know, when we deal with patients who have a higher BMI 50s and more, always we anticipate and predict an inadequate weight loss and a weight regain down the road. So those patients, they might need a revisional surgery down the road or corrective surgery. So the second strategy, you got how to choose the index operation for such patients. So guiding the patient toward the most appropriate bariatric and metabolic procedure is crucial for improving their outcome. An assessment of the value of each procedure is complex. So given the heterogeneity of population affected by obesity and its varying impact on individual patient, we may never identify a gold standard single operation that is best for all patients. You cannot say sleep is the best for all people. You cannot say Roux-en-Y is the best for all people. You cannot say single anastomosis, bypass surgery, and etc., etc. So we don't have an index procedure for all population. So variety of surgical procedure recognized by EFSO and American Society of Metabolic and Bariatric Surgery. So these are the common surgery that we're dealing with nowadays: sleeve gastrectomy, and in the past we did adjustable gastric banding, biliopancreatic diversion, single anastomosis, the SASMBS, or one anastomosis gastric bypass that was invented by Rutledge, and commonly Roux-en-Y gastric bypass, or the first procedure, has been invented. And recently, what's been introduced to the field by Michel Gagne group, MAGD, which is the magnetic dual pathway intestinal diversion side-to-side anastomosis, or they call it magnetic duodenal-ileal switch, or duodenal-ileal bypass. So a randomized control trial that compared sleeve gastrectomy with Roux-en-Y gastric bypass within 10 years of follow-up showed that the Roux-en-Y bypass had a better weight loss than sleeve gastrectomy. And sleeve gastrectomy has a higher number of weight regain and inadequate weight loss with a longer follow-up for sure when compared to Roux-en-Y gastric bypass. And it's often associated with a gastroesophageal reflux disease, leading to a significant number of revisional surgery. A customized proper patient selection for a procedure is mandatory to achieve the best possible long-term outcome after MBS. So you have to choose the right patient for the right procedure, or the right procedure for the right patient. So third strategy, the dietary intervention. So high carbs and alcohol intake might cause weight regain. So there is an urgent need to solidify the scientific knowledge on the best dietary strategies to optimize the weight loss, decrease the incidence of inadequate weight loss, and to avoid and stop and help and reverse the weight regain that might happen down the road. Though few systemic review that showed no link between the weight regain and dietary intervention, but there are few, and there is a lot of contradicting data that's supporting that dietary intake control will do a better help and reduce the risk of weight regain. The most important thing that we have to teach the patient and have in courses before and after the procedure is behavioral and physical intervention. The post-operative behavioral management may facilitate the long-term weight control in the bariatric surgery population. A systemic review and meta-analysis reported that behavioral management positively affect weight loss following surgery. In 13 studies, a recent study, patients receiving behavioral management had more weight loss than those receiving visual care or no behavioral management. A meta-analysis of 5 randomized controlled trials suggests greater weight loss in patients with behavioral lifestyle intervention compared with control group who don't have behavioral style intervention. So, grazing and binging were the most commonly identified eating disorder associated with weight regain. So several systemic reviews showed a strong association actually between the physical inactivity and weight regain. Both approaches are mainly complementary to medical and even surgical intervention for patients with inadequate weight loss or weight regain after metabolic bariatric surgery. So it's like a teamwork. You need to have your dietitian in hand, you need to have your physiotherapist or your trainer in the other hand. So fourth strategy, revisional surgery and endoscopic intervention. So what should we do and which patient we should look after in revisional surgery? So revisional procedure are a growing subset of bariatric procedure and representing almost close to 15% of all the total number of bariatric surgery we're doing nowadays. And the American Society of Metabolic Bariatric Surgery Revision Task Force back in 2014 standardized the nomenclature of various types of revisional bariatric surgery. Although it's safe, but the revisional operation carry a higher chance of complication than any primary metabolic procedure. Potential indications for revisional metabolic surgery include inadequate weight loss, weight regain, and or recurrent of weight-related comorbidities like diabetes, hypertension, and others. Weight regain is the reported indication for more than half of revisional procedure. So we're doing revisional procedure for more than half of the patient just for the weight regain, and the other for the other complication. If revisional surgery is indicated, a comprehensive multidisciplinary evaluation is needed. So you need a psychiatrist or psychologist to look after the patient. You need a good dietitian to see the patient before surgery, and even sometimes you need to hook him to an exercise or trainer just to teach him to take him to the gym or do personal exercises. Plus other facility or other medical specialty we have to. So revisional surgery and endoscopic options after sleeve gastrectomy. The weight regain and inadequate weight loss are more common after sleeve gastrectomy when you compare it to Roux-en-Y gastric bypass and other operations. Some evidence suggests that the development of gastroesophageal reflux disease, GERD, after sleeve gastrectomy may associate with the weight regain. GERD symptoms can lead to a change in eating habits, such as consuming smaller and more frequent meals or avoiding certain type of food that trigger symptoms. And this might cause an imbalance between the carbs and protein and fat intake. It might lead down the road to the weight regain. Multiple surgical alternatives to revise sleeve gastrectomy were proposed, such as a re-sleeving and sleeve glycation for weight regain and or sometimes we do it for a reflux disease. Although still without a robust evidence regarding long-term outcome, there is more data on converting sleeve gastrectomy to Roux-en-Y gastric bypass. There is insufficient data on converting sleeve gastrectomy to single anastomotic duodenal ileostomy, SASMBS, and one anastomosis or ATD. So we have more data for converting sleeve gastrectomy to the Roux-en-Y gastric bypass. So treatment option. This is a systemic review that talking about sleeve gastrectomy is frequently a failure or long-term follow-up. And when we do sleeve, patient will come back after 5 years, 7 years, maybe earlier, just complaining from their weight regain. So insufficient weight loss and weight regain are among possible indications for revision, and incidences range from 50 to 37% of literature, and there is one literature in a systemic review quoted up to 76%. Choice of revisional procedure is dependent on a patient characteristic. Does he have hiatus hernia, patient lifestyle, associated morbidities, as well as the surgeon expertise in a revisional surgery. Among the surgical revisional procedure for weight regain and inadequate weight loss after sleeve gastrectomy, re-sleeve gastrectomy is an option, Roux-en-Y gastric bypass, one anastomosis gastric bypass, single anastomosis duodenal ileal bypass, duodenal switch, endoscopic management, and magnetic duodenal ileal bypass the Michel-Gagne infection. So, ESG analysis showed a PMI revision of 36 kilogram per square meter. PMI, it caused a PMI reduction up to 5.7% in 12 months or 1 year follow-up. The total body weight loss after ESG is being quoted in most of the literature up to it's reaching sometimes 20% over 1 year, a very mild complication, mostly dehydration in those patients. So, and relieving the patient, what we have to do is just reshaping the residual gastric volume. Residual gastric volume was measured by CT colorimetry or perinasal test. The full PMI is about 39.17. They have reduction at the 48 month, almost 10.8 of their PMI if they reduce. Major complications were seen in the 3 cases, and stable line leakage was the prominent in 8 cases. So mostly they have stable line leak. One mortality was secondary to that study was secondary PPE that was happened after 30 days from a post-operative gastric leak of a re-sleep patient. Roux-en-Y gastric bypass, PMI in those patients almost like same like re-sleep, 39.9 reduction, and the maximum PMI reduction was 7.47 at 48 months. Follow-up rate, up to 1 year, almost close to 100%. Major complications were seen. Mainly anastomotic stenosis was the most common. And in that literature, I think the procedure at that time, the gastric anastomosis was a stapler anastomosis. And nowadays, I think most of the surgeons, they doing it just switching the hand-sewn anastomosis. Among minor complications, nutritional deficiency was predominant with incidence of 13.6 in a Roux-en-Y gastric bypass. One anastomosis gastric bypass, the length of piliary limb in that patient goes from 170 to 220, just depending on the PMI of the patient, and they have a good PMI reduction. I mean, the PMI reduction at 4 years' time reached 17.8, and I think it's a hybrid procedure doing one gastric bypass, especially depending on the piliary limb that you create for the patient. Follow-up range up to 4 to 8, up to 12 months, and this shows a great weight reduction, but they have more complication in terms of the reflux problem, which I will talk down the road in a few slides from now. Single anastomotic dural ileal bypass. So their PMI at the start PMI was 44, and just all these patients are post-sleep 44.2, and they reduced their PMI by 13.5 at 36 months from the surgery, follow-up 36 months. 2 studies reported the follow-up 24 months, and they have 88 and 89% respectively of good weight loss reduction. One study reported a follow-up rate of 55% after 36 months. The complication goes up to 6%, including bowel perforation, leak, hernia, and they have a major nutritional deficiency reach up to 32%, and this is a major drawback of the SASMBS. So this is curve showed that the best weight reduction procedure out of those revisional surgery is the one single anastomosis bypass cartilage procedure. In conclusion, the OGB is the best revisional procedure in terms of efficacy and complication rate. OGB led to a PMI reduction of 11.48 after 12 months, and it reached up to 15 in 2 years' time. One study showed a PMI reduction up to 17.8 at 5 years' time. In conclusion, re-sleep was effective with a decrease in PMI 10 at 4 years' time, a relative high rate of anastomotic leak with high rate of complication from the fluid. About the conclusion about the Roux-en-Y gastric bypass, I mean, the PMI reduction at maximum somewhere between 7 and 8. at 4 years follow-up, there was a relatively high complication rate, mainly anastomotic anastomosis for those using stapler gastrogenostomy anastomosis. SASMBS, as I said, has a major nutritional deficiency as a drawback for this procedure, and it is technically challenging as a revisional procedure, but I think the technical challenges of SASMBS being solved now with the MAGD, the magnetic ileal anastomosis that was invented by Prof. Gani and his group. ESG was considered the least effective procedure and led to a decrease in the BMI of 5.7 at 1 year follow-up. It was associated with only minor complication that is related to the dehydration. Study had reported an increased incidence of gastroesophageal reflux disease among patients after laparoscopic sleeve gastrectomy. For those who failed to respond to conventional oral acid-suppressing medication, surgical intervention always comes in consideration. A meta-analysis of 22 studies revealed that 35% incidence of GERD following laparoscopic sleeve gastrectomy. However, some studies have reported even higher rate of GERD post-sleeve gastrectomy, reaching 50% of the time. So what are the mechanisms of gastroesophageal reflux disease that happen after laparoscopic sleeve gastrectomy? Many factors. I try to summarize them in this slide. Reduced gastric compliance after the surgery, elevated intragastric pressure, which is commonly happening after sleeve gastrectomy, and the disruption of the anti-reflux barrier, such as an enlarged Pepys angle and decrease the lower esophageal sphincter pressure. For those who go really high up, close to the lower esophageal sphincter, hiatal hernia is a well-known cause of the reflux problem. Gastric sleeve torsion, stenosis, another factor. Researchers reveal that this angle increase in those sleeve patients, somewhere between 36 to 51 degrees, following the laparoscopic sleeve gastrectomy, and it happened in 78% of the patients who had enlarged face angle or hiatus hernia. So surgical treatment of GERD after laparoscopic sleeve gastrectomy. The most common reason for revisional surgery after sleeve, as I said, is the vertigo, followed by a GERD problem or other complication, with Roux-en-Y being the most frequent performed revisional procedure following sleeve gastrectomy nowadays for those who have Phelps hernia or a reflux problem. Both American Gastrointestinal Association and SAGES consider Roux-en-Y gastric bypass to be the preferred procedure of surgery for these patients with hiatal hernia and gastroesophageal reflux at the date. In tremendous study published by Nandalusu and Hoyana and Filtricio and Diana and others to assess the changes in esophageal and weight loss for post-sleep patients who had a reflux and weight regain before and after Roux-en-Y gastric bypass. The results showed almost close, 83 to 93% of patients with typical reflux symptoms prior to surgery experienced significant improvement post-surgically if we did an Roux-en-Y gastric bypass, with up to 40% of them have lose their weight excess. It is evident that Roux-en-Y gastric bypass has a favorable therapeutic effect in the treatment of gastroesophageal reflux disease and insufficient weight loss after laparoscopic sleeve gastrectomy. Moreover, the complication rate of Roux-en-Y gastric bypass revisional surgery does not appear to be significantly higher than those of primary Roux-en-Y bypasses. For patients who continue to struggle with refractory reflux symptoms after sleeve gastrectomy, Roux-en-Y gastric bypass remains the preferred option for surgical revision. So, OAGB versus Roux-en-Y gastric bypass in post-sleeve patient, a study comparing the conversion from laparoscopic sleeve gastrectomy to single anastomosis or classical Roux-en-Y gastric bypass. They feel that OAGB may offer superior outcome in terms of acid exposure and the mystery score, those who had post-op the mystery score, post-sleeve, even though it was associated with a higher prevalence of reflux symptoms in the OAGB group, and really bireflux. And here there was something, it's a bireflux after single anastomosis bypass, not the gastric reflux. And it has more relation and a link more to the peritosophagus and gas and the esophageal cancer. Additional studies suggest that OAGB might be effective as Roux-en-Y gastric bypass, addressing reflux following sleeve gastrectomy. Just few data, and that's been from Reynolds. This group indicates that the rate of GI commission after conversion from LSV to Roux-en-Y gastric bypass and OAGB were 89 and 87 respectively, which is not significant, but that one study only. Diana and her group found that 77% of patients who underwent conversion to single anesthetic gastric after laparoscopic sleeve gastrectomy experienced a resolution of reflux symptoms and were able to discontinue acid suppression with their averages, and they have a better care quality of life score, and that being dropped from 9.6 to 1.7 respectively. The impact of primary laparoscopic sleeve gastrectomy surgical technique, weight regain, and GERD. Why happen? Laparoscopic sleeve gastrectomy can also impact postoperative GERD. Currently, the main disagreement among surgeons focuses on the distance between the resection line and the pilus, as well as the size of the bougie. It's been controversial. I don't think so it's anymore with the public data. There were 4 randomized controlled trials prove that the GERD reduced significantly if you make distance between the pylorus and the first stable line 4 to 6 centimeters. 41 experts from China, Japan, South Korea discussed the post-operative GERD following laparoscopic sleeve gastrectomy in Shanghai, and that was not far recently in the last 3 or 4 years, and 70.7% of the experts agreeing that starting the resection 4 to 6 centimeters from the pylorus and reasonably preserving the antrum during the surgery might decrease incidence of post-operative GERD. In Shanghai conference, considering the excessive resection of the fundus may lead to rapid gastric emptying, affecting patient dietary control and weight loss outcome. 85% of experts agree that to recommend the use of bougie 36 to 38, not tighter, not wider, to ensure surgical effectiveness in terms of weight loss while reducing the incidence of post-operative GERD. I'm not talking anything. The prevailing recommendation within the medical community is to revise sleeve to Roux-en-Y gastric bypass surgery. The revised Roux-en-Y gastric bypass surgery has proven effective in controlling post-laparoscopic sleeve gastrectomy reflux symptoms, better weight loss, and enhancing patient quality of life. Okay, so I think most of us is familiar with this paper, that the Omega trial that was done by the first group back in 2024, they involved 9 centers from France, and it's been published in the Lancet in 2024. They included randomized 253 patients, 5 years follow-up. So they compared both Roux-en-Y gastric bypass versus OAGB post-sleeve gastrectomy. So in conclusion, in those 2 arms, they have a similar weight loss. They have similar metabolic remission of complication or comorbidity, including diabetes type 2, but they have the OAGB, they have a pathological GERD of 41% versus 18%, and it's mainly bile reflux, which is always a concern. So I want to finish my talk with this paper, Surgical Treatment Strategies for Gastroesophageal Reflux After Laparoscopic Sleeve Gastrectomy. I would highly recommend reading this paper. It's kind of an overview of all what I mentioned. I think I'll finish with this, and thank you very much.
Well, thank you, Prof. Bawahab, for this informative presentation and summary. I will leave the discussion to Dr. Dalbour to moderate the discussion. So, Dr. Dalbour, the mic is yours.
شكرا دكتور عبد العزيز. شكرا دكتور عبد الرحمن. Special thanks for Dr. Professor Bawahab for his nice presentation. If you have any question, ما أدري الدكتور ظافر إذا موجود ولا لا. أنا ماني معلش على الجوال، فما أدري إذا الدكتور ظافر معنا ولا لا.
ما أدري if anybody need to be admitted. I'm not sure.
I don't see his name on the participant, so you can proceed the discussion.
So we need, if you have any question or feel free to pose it for Dr. Professor Bawahab.
Any questions?
Abdullah, there are some questions on the chat if you can look to it and
المشكلة إني أنا على الجوال معلش
okay,
والله.
so I'll
فإذا
start the
تقدر دكتور عبد العزيز.
questions.
أيوه.
Sure.
Can I
So
ask a question, please?
okay, you can start your question and then we'll proceed with the chat.
I'm reading what
Thank you, Prof. Bawahab. I'm Dr. Mohammed Abu Khater, King Fahd Medical City, Riyadh. Can I ask? أنت طيب، كل عام وأنت بخير، يعطيك العافية دكتور بوهاب. Excellent and very comprehensive presentation and in all aspects. But my question here, you presented as the question in the that weight regain with hiatal hernia, both sleeve gastrectomy. So I think the option is very limited, because if you have hiatal hernia, patient sure will have a reflux symptoms. In these things, if we are going to do OGB or SADI, it will be a little bit difficult to decide to these cases, because as you mentioned in many of the study, the reflux is more post this procedure. But the only option we have the Roux-en-Y gastric bypass. But the only problem that in case we have a super obese patient, post sleeve gastrectomy with hiatal hernia, Roux-en-Y gastric bypass will not be very effective. So what do you think the best procedure in these cases, Dr. Bawahab?
Well, having a big hiatus hernia, and to be honest with you, looking over the data, like patient with hiatus hernia and need a weight reduction surgery, and he's if the patient is fit in term or condition and his weight not that the big super obese patient, I think patient will go for Roux-en-Y gastric bypass. And honestly, I did not find a supportive data to support even closure of that hiatal hernia during Roux-en-Y gastric bypass as a revisional procedure. But for the super obese patient that you're talking about, I think I will still do the Roux-en-Y gastric bypass in the presence of revisional, in the presence of hiatus hernia. But here it comes to the role of the judgment of the measurement of the limb, which limb you're going to make bigger. You might elongate the piliary limb more, and you will achieve better results. Like, I mean, I do my piliary limb an average 100 to 120. For a super obese patient that we talk about, I go from 150 to 200 if I have to. The piliary.
I agree, Dr. Bawahab, but what do you think the data regarding this, in this super obese patient, you are going to do Roux-en-Y gastric bypass, whatever the measurement in biliary and elementary in revisional surgery, still we have very limited, result.
I know. That's what I'm saying. I mean, if you're talking about SADIs is it's a big procedure. I mean,
No. I'm not talking about SADI. I'm talking what you think the best options. What's the best options? If you have a patient with BMI 80 or 70, and you have still hiatal hernia, both sleeve gastrectomy, doing Roux-en-Y is not the best option in these patients, whatever the measurements. That is what we do. We usually do Roux-en-Y gastric bypass in case we have hiatal hernia.
well, going through the literature, I found supporting data to do even a single anastomotic gastric bypass with closure of the hiatus hernia, but you're helping them and treating their weight loss or weight regain, and you give them a better weight loss, but you're not helping them in terms of their GERD. So kind of controversial, try to fit the patient to the right procedure that you have. Do I do OGB for a big patient? Yeah, I do them, and sometimes I close the hiatus hernia. But thing will be explained to the patient ahead of time. I mean, during the counseling the patient, which procedure will give him a better weight loss and what the downside of that procedure. So I will stick to the Roux-en-Y gastric bypass. And infrequently we see those highly morbid obese patients, the 70s or 80 PMIs, as a revisional procedure. But I will do Roux-en-Y bypass myself for an average PMIs. I mean, the regular that we see 50 and below. For the higher PMI, they will need single anastomosis gastric bypass. But patient has to know ahead of time that he might suffer from the GERD symptoms. This is my options or my opinion in those patients.
Thank you.
Okay,
tell me
Doctor, go ahead.
مخاطر.
Thank you. No comments. But are you doing in these cases manometry and pH monitoring just to be sure in case you are not going to do Roux-en-Y gastric bypass, like you said OGB? The problem, as recommended by ACMBS, that OGB is not a good revisional, or is not recommended as a revisional surgery.
Exactly. That's what I said. It's not my first option. Okay, but a patient we need a better weight loss, and knowing the sequelae of that procedure, I might be pushed to do single anastomosis gastric bypass. And to be honest with you, I had done it once for a super obese patient that he came back after sleeve gastrectomy with a BMI 73. But most of the patients are doing them like gastric bypass.
Thank you. Great. Thank you.
So let's jump to the second question since Dr. Abdullah cannot see the chat. Dr. Faris Sharif has a question. Could you share your approach to the limb length in terms of Roux-en-Y gastric bypass, whether like talking about primary and revisional cases?
I didn't get the question. There is a
So
sound.
what's your limb length in terms of Roux-en-Y gastric bypass if you are doing it for primary procedure or doing it as a revisional procedure?
So what's my indication for Roux-en-Y gastric bypass?
Sorry, what's your limb length for Roux-en-Y gastric bypass if it was done as a primary procedure for weight loss, or if it's done for revisional procedure? Are you doing different length for the Roux-en-Y gastric bypass, or are you using the same length for both procedure?
No, not the same. I mean, usually there's a room to play with the piliary and the. I mean, it depends what I'm doing in the procedure. Do I do it for a weight regain or I do it for a reflex problem? If I do it for a weight regain, I will elongate the piliary limb. Won't be less than 150 for 120 centimeter to 150 centimeter for weight regain. But if I'm doing the procedure for a bad reflux problem in a thin patient that he suffered from that with a big hernia post-sleeve gastrectomy, I will be more elongating the alimentary limb. So that won't be less than 100 centimeter, minimum 100 centimeter. I know some people, they go for 70 centimeter alimentary limb, but I go for minimum of 100 centimeter in cases of the reflux, if the indication is a reflux problem.
So we have a question from Dr. Osama Sane. He's emphasizing on avoiding using some terms like weight regain and replacing it with disease recurrence, even replacing the insufficient weight loss with suboptimal response to treatment, just to avoid the focus and confusion and weight in metabolic bariatric surgery. So he would like your view on this kind of things. And we know that weight matters, but do you agree that we have to avoid using terms stressing weight as a target of therapy?
I read this question because there is a problem in the sounding system, but Dr. Bao have one of the most important concepts in the bariatric metabolic surgery, whether by EPSU or SMBS or SASMBS even, is to avoid using terms such as weight regain and replace it with disease recurrent. Yeah, it depends. Well, my answer to this question, it depends. What are you doing the procedure? Are you doing it for a metabolic reason or just for a pure bariatric weight loss problem? I mean, if you're doing it for a metabolic reason, yes. I mean, you're doing it just to treat, aiming treat or remission of the associated diseases. Yeah, I would say for a disease recurrent. Yeah, I would agree, Osama, with your comment.
I think we have last question by Dr. Haider. Dr. Haider, would like to see your question?
شكرا جزيلا. وصراحة الميتنج مثري ومغني. هذا أولا. ثانيا أنا I think the question of your lecture was very specific regarding weight regain post sleeve with hiatus hernia associated with GERD. In this situation, well, I think all of us will agree that repair of hernia will be one of the target of the revision, because the revision is because of these two things. But the second point, which is the revisional procedure or the conversion, is here is the question where if we choose one anastomosis, or we choose SADIs, or we choose SASI, whatever now they try to label them. What do you think about the bile reflux as well as recurrence of the reflux if we choose SADIs? Because as you mentioned in this study, which has been published, there's still a problem with the SADIs. They have recurrent reflux. And if we do one anastomosis and we get recurrent, then we have a double reflux, acid and bile reflux. And in this situation, the things will be worse. So what is in your revision of data and your experience regarding the bile reflux in single anastomosis? Because you have mentioned that literature has also did not show very strong evidence repairing of the hernia. Although there is 15 to 17% of patient who doesn't have repair of hernia and went for Roux-en-Y bypass, they still may have recurrence of reflux. I will be so thankful if you give us some about your experience and your review.
Thanks, Haider, for this question. My answer to this question and the consensus of the singular anastomosis gastric bypass in the SAD is that you should not do them for patients with reflux problem or hiatus hernia. You should not. I mean, this is the SASMBS, the MBS and the AFSO guideline regarding that. The other thing, Omega trial, it is very obvious and it's a recent and it's a reference actually for SASMBS as well as EPSO. Omega trial stated clearly when they compare Roux-en-Y gastric bypass with single anastomosis gastric bypass, they have the same weight loss, they have the same remission of the comorbidities, but the OMG or the single anastomosis gastric bypass, they have a very bad reflux, and especially bile reflux. It's been recorded in 41% of the patient when you compare it to Roux-en-Y gastric bypass reflux that, as you mentioned, only 18. So it's very clear that the single anastomosis gastric bypass is a reflexogenic procedure when you compare it to the gastric bypass, the classical gastric bypass.
Thank you. شكرا جزيلا.
There is a question here by
Dr. Sultan. He has a question regarding re-sleeve for poor weight loss if the sleeve gastrectomy was not done properly. Yeah. And in that case, do you call it a sleeve gastrectomy or call it wedge resection?
Well, it depends. It depends what you find. First of all, if you want to do re-sleeve, I don't do them myself. I do not re-sleeve patient at all as a revision procedure. I never done it, and I don't want to do it because I know as a fact that sleeve gastrectomy is a long-term failure procedure for a weight loss. Like most of the sleeve patients, they gain weight sooner or later. They start to gain weight from 3 years and above. So I will not give them another failure procedure, especially if the patient himself is not he's on a good regular follow-up, he's on a dietary control, and exercise control. I will not do it for them. And the data in that paper that I share with you, re-sleeve, they might give them a good weight loss initially, but they will regain weight with a very bad complication if it happened. If you leak a re-sleeve patient, it's a disaster sleep. You don't have much of the stomach to suture. You don't have much of the stomach to bypass. So I won't do them. I'll give them a safe procedure, either single anastomosis gastric bypass, or I will do them the Roux-en-Y gastric bypass, or even MAJD or magnetic procedure now. It's a very accessible procedure to do. This is my answer to Dr. Al-Mulham.
We have two more questions, one from Dr. Hisham Harun. If you would like to answer the question or would like me to read it first, he's asking of what we should do if the patient has an optimum weight loss after sleep, but he has only hiatal hernia. Prof. Bawaha, go ahead.
Listen, I was reading the question. Dr. Harun question, if the patient has a good or great weight loss and came with hiatus hernia and a reflux problem, would it be sufficient to just close his hernia without doing a bypass procedure? I will say no. What I'll do with him, just I will close the hernia, I will do a bypass procedure with a short biliary limb. Here it comes where you decide about your limbs, short biliary limb. I mean, from 50 to 70 centimeter, and I will give them a longer alimentary limb, not less than 100 centimeter, but always I will bypass them. I will not close the hernia alone by itself because it's a failure procedure. And we know even in non-obese patients, those who have a hiatus hernia, it's a combo procedure. It's a hiatal hernia repair plus fundoplication. So you don't have a fundus here to wrap it around the stomach and to create or to augment your lower esophageal sphincter. So my answer to Dr. Harun, no, I'll do bypass. Going to Dr. Osama Sana question.
Can we stop here, Dr. Bawahab? What if the patient has an optimal weight loss, he has no esophagitis, and the manometry did show that the patient has good manometric studies? Will you do a LINX procedure?
I'm not in favor of LINX procedure. I see LINX as a foreign body when we start doing the lab band, and now we're removing lots of LINX. With my respect to Dr. Ashraf Maghrabi, he's my friend and he's the guy who's going after LINX. I see more patients now coming to my clinic with LINX, that magnetic magnet ring. They want to remove it. They have bad dysphagia, and I have seen, not in my patient, okay, I have seen a disastrous complication like erosion of the LINX. I mean, just recently we stopped seeing complication of bands because we abandoned doing band or nobody doing band recently. And I think this is the future of LINX.
We have last question from Dr. Osama Sana.
So Dr. Osama is asking the issue of Rowan Webber not being an effective procedure.
I'm not asking a question, sorry, and I was commenting, agreeing with you about the BP limb length. That RYGB, then Dr. Abu Khater said that RYGB is not a good option in high BMI. And I don't agree with that. I think you eloquently said it. If you control the BP limb, you will have the same result as one anastomosis, as any other procedure. What determines it is the length of the common limb, more or less, that you've left behind. So if you really consider the adjustment and the sizing of the limbs together, you have the BP limb lengthening as a procedure itself has been studied well and showed to be effective as a revisional procedure. The issue is not that, is that the response is variable. Some patients over-respond, they end up in liver failure, end up in malnutrition, and some patients under-response. It's not only related to the procedure, but it is related to the patient factors. So we have to consider that you take a gamble when you do these things. You know about the toll of 4 meters. That's not like written in stone. You may not have a good result with a patient. You do 4 meters, or you may have an over response, you may have an under response, because we do not really understand how the small bowel behave in a particular patient. So RYGB, I agree with Dr. Bawahab or Professor Bawahab that it is an effective procedure if you adjust the limb lengths, whether short for a patient who's in adequate weight loss and coming with a hernia, or whether the patient needs weight loss and and he's a high BMI, you need to go for a longer BP limb. I support your view on this point, and I need people to understand that this obesity is a genetic disease, more or less, a hormonal disease. So let's not put it all on the surgery itself. That was my view, and I want to hear your opinion on that.
Honestly, I didn't get what you want because I didn't hear you well. There is a sound problem. Like I was reading your point here, but I think what I gathered from what you said, and patients are not the same, and the indication for surgery is not the same. Sometimes we're doing the surgery for a weight regain. Sometimes we're doing it for a morbidity control, like diabetes and others, and sometimes we're doing it for reflux problem. So, and as I said earlier, there is no standard procedure for revisional surgery for bariatric procedure. So you have to tailor the procedure to the patient. So why we're doing the procedure? I'm not doing it for a bad reflux problem. I'm doing it for a hernia that's clearly evidence on the endoscopy and in the bariatric swallow, or I'm doing it just for a recurrent of his diabetes, which is not controlled diabetes. So here it comes where you choose between the right procedure and for the right patient.
هو في فكرة جدا واضحة محمد وأسامة أشرتوا لها. يبدو لي أن التوبك هيتال هيرنيا and weight regain. فبما أن الهيتال هيرنيا والweight regain both will get achieved by Roux-en-Y bypass, as the Roux-en-Y is the anti-reflux procedure وده will add to it with hiatoplasty. لكن الويت كنترول او ويت ريكارنس كما الان يحبون نقوله اعتقد هنا ياتي الميجرمنت and I support the measurement of all limbs that is the BB limb, raw limb, and camel channel. I think all limb will be measured in order to get the final. But what you said about the metabolic disease, reflux, weight recurrence, all these which we can say they are objective reason for our revisions. But the subjective reason, these are what Osama clearly said, that which we are not controlling them. Behavioral, psychological, all these things. Very good. شكرا لك والله يا دكتور محمد، دكتور عبد العزيز، كلكم والله ما شاء الله أبدعتم.
We have two questions. I would thank you, Dr. Haider. Dr. Ahmed Shamia, he has a data he would like to share from John Hopkins Aramco. If you can, Dr. Ahmed, can you share your data, please?
I have a comment in what Haider Sharaf has said, and I think.
السلام عليكم. أنا الأمانة عندي معذرة، أنا الأمانة ما كنت ناوي أتكلم، لكن خليني أوخر عن العائلة. عندي data تقريبا 55 cases on this subject, hiatal hernia, post-sleeve gastrectomy, and these patients are symptomatic. It's critical that we pick these symptomatic patients because there are patients with hiatal hernia post-sleeve but have no symptoms. So I have about 55 patients that I performed, or Dr. Madani performed hiatal hernia repair and convergent Roux-en-Y gastric bypass. The vast majority of these patients, their GERD resolved. Some of them just improved. And we have about 2 or 3 patients that had just hiatal hernia alone. These patients did not do as good as the bypass patients. And there is a subset of these patients that had a very high BMI. We're talking something around 45 to 55. For these, obviously, we did an adjustment of the BPLM. And we count the small bowel length in all of these patients. So anyone who has a sleeve, and we're revising, will count the entire small bowel. And based on the small bowel length, we'll decide what's going to be the BPLM or the roux limb and the common channel. The bottom line is the revisional surgery should be tailored based on the symptoms of the patient and the anatomy. If there's a hiatal hernia, it should be fixed on the time of revision. Because you may just do a bypass and the patient's symptoms does not improve. And you may do the hiatal hernia without the bypass and the patient's symptoms not improve. So based on our center experience, you got to combine both procedures at the same time. Now, mini gastric bypass is an option, but a lot of these patients come back with bile reflux. So I personally don't do it. In fact, I revised maybe 10 of these cases myself. At the end of the day, we have to combine the data, our center's data, and publish them. Because without publishing the data, it remains opinions and personal experiences. So inshallah, in our upcoming meeting April or May, I hope I can present this data formally.
So thank you for Dr. Ahmed for sharing this data. Going back to the comment of Dr. Haidar Al-Shurafa and Usama, as I stated earlier in my talk, when you're going for a regional surgery for myself and for others, it's a now it comes the role of multidisciplinary. It's like one man show decision. Okay, you need to involve all the people. You got to involve the psychiatrist, you got to involve the dietitian, you got to involve the GI, gastroenterologist, if you have to, depending on the case, radiology. So you got to take the patient as a package, not just like a primary procedure when you do. And you have to find what's the reason of the weight regain. Is it a behavioral problem? Is it a genetic problem? Just technical problem from the first procedure. So that I would agree what Pim commented, which I mentioned in my talk. Thank you very much.
Prof, we have one last questions.
معلش عذرا عبد العزيز عندي تعليق لأنه it has been mentioned in couple of slide of محمد مع جزيل الشكر لهذه الأمسية يعني أنت you mentioned there is no index operation. You are totally right. And we cannot have an ideal operation, as we all agree about that. But in the opposite direction, there are cases or patients, they are contraindicated for the procedure. As you know, Barrett's, they should not do sleep, for example. So we can select patients who should not do the operation. But yes, as you have said, we cannot have an operation which can fit everybody. Shukran jazeela.
So we have last questions by Dr. Buseri, and then we'll go to Johnson & Johnson presentation. They are the sponsor of our meeting. So Dr. Buseri has a question regarding what the size of hiatal hernia matters in terms of if the patient has a reflux and you're going for Roux-en-Y gastric bypass. Well, Roux-en-Y gastric bypass alone is enough without doing hiatal hernia. So that's going to be the last question before we go to our sponsor presentation.
Well, doing the sleeve as a primary procedure, I find hiatus hernia that's clearly seen, even just sinking down of the tissue to the hiatus, I will repair them. And usually I do the posterior repair. I don't do fundoplication. I don't leave a gastric fundus just to wrap it around the upper portion of the sleeve. I do just a standard sleeve, 4 to 6 centimeters, mostly 4 centimeters from pylorus. As all knows, I avoid the G-junction. I do some laterally. I go to the base of the crura on both sides, and if I see clearly seen hiatus hernia that has not been seen or been diagnosed pre-op, or patient has no reflex symptom, yes, I do that. I do that with interrupted cruroplasty and absorbent suture, and I think we do well. I don't have a long data of them, or I did not follow them for long. Patients, they don't come after the second or third. This is actually what I do them regularly.
Well, Prof. Bawahab for the discussion and the informative presentation. We will have Mr. Muhammad Amr, the rep from Johnson & Johnson, to share his presentation. We'll have less than 5 minutes, and after that, we can proceed with discussion if there is any time. So, Mr. Muhammad, can you share your slides, please?
Absolutely. Thank you, Dr. Abdulaziz, and thank you, Prof. Bawahab, for this great talk, and thank you for this great discussion. Good evening, everyone. I'll try to be very fast. It was a very fruitful discussions and questions. Let me share my screen.
So while Muhammad presenting his bringing his slides, can you, there is a form down on the chat for 4 CME hours. Please submit your data and information so you can have 4 CME hours.
Thank you. So good evening, everyone. My name is Muhammad Amr. I'm the Senior Business Development Manager from Johnson & Johnson MedTech. And today my presentation is going to be on science of energy and bipolar technology. Our bipolar technology, which is in CLEX-1. If you remember last time, we talked about harmonic technology, our ultrasonic technology. And today we're going to talk about bipolar technology. as we mentioned last time, we know that the energy devices are not a secondary instrument in bariatric surgery. They are determinant of bleeding, visibility, safety, and thermal damage that will happen to the tissue. And we all know why energy devices are used in surgery. They are used to achieve two main actions, which are cutting and hemostasis. And these two actions lie in opposite ends of a balance. Previously, in the old times, devices that used to cut well did not achieve hemostasis well, while devices that achieved hemostasis did not cut effectively. But the introduction of harmonic and ultrasonic technology introduced what we call hemostatic cutting or simultaneous cutting and coagulation, and this was soon followed by the invention of advanced bipolar energy devices like LigaSure, like InSeal. And as evidence shows, these advancements have had a dramatic impact on surgical efficiency and on surgical time. In surgery, we utilize two main kinds of energy devices, either electromagnetic energy or bipolar energy or monopolar energy, where we pass electrical current through the body of the patient, and we see the effect that on the tissues from this electricity or current, or mechanical energy or the energy of motion, like ultrasonic energy, where you use a moving blade to achieve the hemostasis. Since as bariatric surgery, you're dealing with big vessels like the short gastric vessels, hemostasis, I believe, is a big need for you. And in order to talk about this, we have many factors that affect the sealing capability of the energy device. We have two sets of factors, either uncontrollable biological factors, things that you cannot control from one patient to the other, from one tissue to the other, like collagen and elastin and water content. And then we have the controllable physical factors that we as a manufacturing company of the energy devices can control in our device in order to achieve better hemostasis, which are compression, heat, and time. Collagen and elastin, they are two opposing proteins that react in a different way. Water is an extremely important factor, especially when you're using an ultrasound, especially when you're using an advanced bipolar energy device or electrosurgical device, because water is the main determinant of thermal spread and heat. Especially if you're using an electrosurgical device, it's the main cause of why thermal spread would happen from an electrosurgical device, because when the energy flows through the tissue and the water starts to evaporate, the resistance will rise. And then the electricity, because it's lazy, it seeks the path of least resistance. So instead of going through the targeted tissue between the jaw, it will seek a pathway through the surrounding tissue, which still have high water content and low resistance, like you can see here from this video. If we're talking about the controllable factors, compression is important. Compression brings the vessel wall together and also pushes the water content, so the heat will rise faster, which makes the energy device faster. Heat is important, but what's the amount of heat that is needed? This is the window from 60 to 100 where you want the energy device to operate and where the thermal spread is minimal. Before that or less than that is the tissues changes are reversible, and above that you have desiccation, you have carbonization, and you have thermal spread. Why thermal spread is important? Because you're dealing around vital structure, like when in sleep, when you're working around the spleen. With less thermal spread, you have less inflammation, faster healing, less pain, and improved dissection and separation, especially if you have a lot of adhesions and you are working in between delicate planes. So bipolar energy devices, as you know how they work, electricity is operated between the two energy electrodes. But the problem is with the traditional bipolar is what we said is the thermal spread, because the energy is not controlled. You set the machine at a certain power level, and it's not controlled. Whatever happens to the tissue, it's not controlled. It will deliver the same 50, 40 watts that you are delivering from the generator, no matter what's happening to the tissue. And when we call this bipolar device an advanced bipolar device, when we increase the compression, when we have a better compression, and that's why advanced bipolar energy devices like InSeal can seal vessels up to 7 millimeter. While traditional bipolar energy devices, because they lack compression, they can seal only 3 millimeter vessels. Also adaptive controls. So with advanced bipolar energy devices, the energy is not standard. It's not specific power level. That's why you cannot see like 50 watts or 40 watts, because the energy is variable. You have integrated cutting, so there's a knife inside the blade, and whenever you have all these factors in a bipolar device, then we call it an advanced bipolar device like the InSeal. What's the impact of that on the tissue? Here, fundamental difference between bipolar and ultrasonic is that the heat is generated first in the tissue, and then it's transferred to the device. And that's why the tissue is always hotter than the device. The device is usually cooler, while on the other hand, in the ultrasonic, the heat starts in the blade and then it's transferred to the tissue. And that's why the blade is always hotter than the tissue. But that doesn't mean that it creates more thermal spread. The main cause of thermal spread from an advanced bipolar energy device would be the current. Like we said, when the water evaporates, it goes to a different pathway, what we call current. We have convection from the steam, and we have conduction. Still, the bipolar energy devices get hot, but not as hot as the ultrasonic, but this is not related to the thermal spread. Finally, I want to show you the InSeal X1, the latest we have from the advanced bipolar energy device. We compare here the InSeal to the main competitor that we have in the market from the advanced bipolar, which is, you all know about it, it's the LigaSure. So if we're talking about the curved device, we compare it with the Maryland. It has 16% longer jaw, 19% longer cut length than the Maryland, which will make it faster. It takes bigger bites, and there's a bigger chance that you accommodate the vessel within the jaw because it has longer jaw. So you would be sure that it contains the vessel inside so less possibility of bleeding. It also has 9% wider jaw aperture, which makes you capture more tissues per bite. It has 360 degrees rotation, and you can find the sealing and cutting button both within your 4 fingers, so you don't have to use 2 fingers to seal and cut. Both you can use 1 finger. Same with the ergonomics with the InSeal X1 straight. Comparing to the blunt tip, it has 10% longer cut length, 6% longer jaw than the blunt tip. And finally, when you're talking about sealing, it has a very high sealing capability because of the adaptive tissue technology. Adaptive tissue technology is the technology that controls the energy delivery to the tissue. It's present in the harmonic, and it's also present in the InSeal. So the curved jaw has 22% higher burst pressure than the Maryland. The straight jaw has 90% higher burst pressure than the blunt tip with very minimal thermal spread. Thank you. It's available for trial. If you wish to trial, you can contact us, and we can be happy to supply it to you to try it. Thank you for your time, and thank you for the great evening.
Thank you, Mr. Amra. I have tried it. It's fast. The good thing that I think it rotates 360 degrees. That's one advantage of the InSeal. I'm using it also for the bypass. So thank you for your presentation. If anyone has any question for Mr. Amra, please go ahead and ask your question. If you haven't tried it, we will try in our next meeting to have an on-site meeting, and hopefully we'll bring the InSeal device so you can try it during our physical meeting. So if you have any question, please proceed or raise your hand.
Thank you. I think there's
looks like no questions. So we'll try to bring it for our next meeting physically, so you can share, we can use it together and go through the machine. So by that, I will end our meeting. Thank you for your attendance, for the discussion and everything. That's conclude our 5th meeting of SASMBS meeting. So we'll see you on next week. Good night.
Good night. Thank you.